It's lovely to be here. Thank you, Anne-Harriet. And thanks for the great talks so far. So you will see a certain common theme developing, and I'm going to show you some more data today. But I thought we should probably just start by a reassuring reminder, of course, that there are many protected characteristics, and it is against the law to discriminate against any of them. Some of them are more explicit than others, but actually we have this important imperative to make sure that we are fair to all, enshrined in law. So whether this applies in terms of medical training because of social, legal, and moral justice, whether it's about progression of university graduates, whether it really is about fairness to all, there are lots of reasons why this is important. In terms of progression of university graduates, the Office for Students budget annually is 1.4 billion. That excludes the amount, of course, that's spent through tariff on undergraduate medical training and the amount that comes through for postgraduate medical training. This is a huge amount of money. 1.4 is global, it is across UK education, not just health. But for many reasons, it is essential that we get this right. I might sound a little bit like an advert for the GMC today. I think I might have crashed various bits of their website several times this week. Actually, there is a huge amount of data that's available on the GMC website, where you can pull apart performance for different specialties in different places according to different attributes. Those of you that like to geek out with data, you will lose an evening there without even trying. I would thoroughly recommend it. The GMC, of course, has standards for education and training that we know well, and enshrined in those are ones around fairness, on exploring root causes for aspects such as differential attainment, and on raising the awareness of this with trainees and with trainers. So there's more guidance, more published progression data, and they sponsor and commission research, such as some done by the Royal College of Psychiatrists that I'll touch on briefly later. But essentially what we need to realize is that differential attainment, differential performance by different groups of people in exams, is probably a symptom of what is going on. It's the thing that we measure at the end of it. It's the thing that's obvious, but it's not necessarily, and probably not at all, the underlying cause. So this is some very generic data. I don't do numbers, I'm afraid. I prefer the pictures, but you can see here, GMC progression reports, that there is a statistically significant difference in the pass rate of doctors in exams, depending on whether or not they've been part of a training program or not. It really is that simple. And here is an example pulled down for a pathology specialty, where you can look at pass rates by different deanery. Each deanery has its different strengths and weaknesses. If I showed you this for another pathology specialty, it would show you a different picture. But enshrined in this, we can see that the trainees at some deaneries, so this is trainees, CCT, training people who are registered on programs, there is a differential in their performance across a range of factors, and protected characteristics are not the only ones. Some of these might confound, and in fact, if you look at the data to a greater degree, you will see that they do. So what's really interesting about the GMC website is that it shows you more in terms of differential performance than that just relates to exams. So it also shows you RCP outcomes. And here is an example of some. So again, this is medical trainees. So it's people who are on programs. And it shows you differential attainment here based on ethnicity and how that changes with age. So there is the confounding actor of multiple protected characteristics that pile on top of each other to create this unequal measure when it comes to progression through training. Here's another one where we can see how gender and ethnicity play together. Again, this is for another pathology specialty, and show how aspects that really are beyond medical trainees' control, of course, alter what happens. So if you're going to think about the progression through to a successful female doctor, and I put female for this stance, then there are challenges here. But challenges of postgraduate training and postgraduate exam attainment and postgraduate progression through ARCPs, of course, is only a small part of it. So this is some data from a large UK medical school that has one of the broadest, most diverse range of populations. It's a school where almost 50% of medical students are Asian. And in this school, what the researchers were able to do was to go back through admissions and look at every stage in the admissions and see how ethnicity or colour played out that way. So they showed that the proportion of white applicants who were interviewed was 46%. It was highest in those of mixed race, but only 25% of those who were Black who applied were interviewed. They only 25% reached that far in the application process. Now, why was that? Most people who apply have met the criteria for entrance. So is it that they're not being encouraged? Is it that their applications are less good? Do they not have the same possible inside help with writing personal statements? Do they not follow those processes? Do they not make themselves as glossy as other students? What happens there? And this kind of variation continues. So if you just take the proportion of students who were interviewed, so of the 46% of white candidates who were interviewed, 92% were offered a place. But only 79% of those Black students who were interviewed were offered a place. So was it that their performance at interview was less good? Was there unconscious bias in the interviewers? This is based on 2 interviewers from a range of backgrounds, and a large number of the interviewers here are of non-white background themselves, but there are differences that are coming out here, and they are not easy to dissect apart. Again, it continues, because if you follow that through, the proportion of Black students who accept their offer is highest. That may be because they're given fewer offers, of course, they have less choice, but then that becomes a problem because they are the group that is least likely to accept, to reach their grade target, which means that they are then least likely to be able to accept their firm offer choice. There are, when you understand this data, you can make subtle adjustments, and many universities do, but you know, this happens after education, after school education, and it happens before postgraduate medical education. So what we're looking at in terms of ARCP data is just one small chink in all of this. In terms of what causes differential attainment, there are a range of theories and proofs and probably contributors, and I've listed some of them. Cultural competence, of course, being increasingly important both for educators and for people who educate at all stages, to ensure that these differences don't manifest any more than we can possibly help. What is the aspect of the hidden curriculum? How do peer groups input? What are the different pulls on life? How does somebody who's perhaps living in a foreign country, doesn't speak the language as well, have left their family and their children at home, how are they going to fare in a postgraduate training program compared to somebody who's around the corner? Again, on the GMC website, there are a large range of resources in terms of work that's being done, both commissioned by the GMC and otherwise. I particularly like this report, which came out in 2019, and it looks at UK-trained doctors on programs that have a wide range of differential attainment, and it tries to explore what are the factors that cause that. And here are some quotes from people who have gone through UK medical education and what they feel is playing at play. And I think these are really powerful. These aren't about numbers, these are about feelings. And I think they really do show you, even to people who are used to working in NHS hospitals, about the differences that we see. This study came across 10 factors that could be used to help make a difference in terms of differential progress, let's call it that, in terms of closing the gap. And some of them clearly relate to environment. So being surrounded by people and educators who value diversity, who demonstrate that they value diversity, being in that sort of environment. People who treat trainees as an individual and are perceived by the trainee as treating them as an individual as well. Those who are surrounded by inspiring seniors who may or may not match their own ethnic capacity, characteristics. Those who have a particularly supportive trainer, although difficult to know what is meant by supportive in those words. Those who are in areas where there are strong networks for peer support. So in more diverse areas where there are people around them who are more open to these problems and more openly supportive around that. In terms of aspects that really support learning, well, quite often this group of trainees have reported that it's about being in a position where a certain degree of flexibility is possible in terms of a rota. You're living by yourself, yes, go at 3 and collect your child, come back to work afterwards. Things that make training possible, things that make it possible to maximize learning within the working day and around that. So opportunities that really highlight the capacity for learning from everything that the trainee is doing. Trainees that come in with real career clarity and are given really good career advice are doing better in these circumstances, and those that are helped to navigate the exam. So those who understand very clearly what is being tested, how it is being tested, the journey, the point at which they should be sitting exams, feel that they are more supportive and are more amenable to do well. And the group of trainees did also identify that lots of this was internal and was related to motivation and drive. But of course, motivation and drive in turn are affected by all these things, as one would expect. This is another study, and it looks at something called degree of dissonance. So it puts this into 4 categories. So differences between ethnically diverse medical graduates and those who aren't, in terms of the language they're speaking, the culture they are used to, the education that they have had beforehand, and their sense of belonging. And sense of belonging, again, is something that's difficult to measure. And lots of it speaks to that supporting network of peers that I talked about previously, but it's really high on the agenda in terms of improving outcomes and narrowing gaps. So this group also talks about how dissonance appears in the work environment and actually how it occurs outside as well, and how these things put together. The group talked about when an international medical graduate starts, there being a period which is really challenging at the beginning when dissonance is most stark. But those who survive it then thrive it. So the case then comes back into early support mechanisms, opportunities to really make sure that induction is doing what it should do, and early peer support. Again, harking back to the diversity, making sure that everyone's able to dance, as we heard earlier this morning. Now, when I showed you this slide before, I purposefully left what I think are the most important 2 things off the bottom of this slide, which is the necessity for us to provide a workforce for patients, and also for that workforce to represent worldwide society, to represent the patients that are being treated in the UK in this case, and their diversity. Everyone has a right to feel included when they are being treated, and every doctor certainly has a right to be able to contribute. Again, from the GMC, this is a really useful infographic, I think published in 2020. So right at the beginning of COVID, but largely based on doctors' pre-COVID experiences. And it shows, for example, that by 2020, the number of licensed doctors has grown hugely, but more international medical graduates are being given a license than trainees who have a UK PMQ or are from the EU. So we are in a situation where we are increasingly reliant on international medical graduates, and therefore for patient safety for the future workforce, it is absolutely imperative that we do all we can to make sure that their journey is secure and stable and safe and fair. Aside from anything else, we need to make sure that international medical graduates who are training continue to work within the UK for the provision of healthcare. And the GMC is really committed to this, and they've come out and stated that as part of their corporate strategy, they want to eliminate inequality in medical education by 2030. They've highlighted 2 areas in which they want to do this. Number 1 is around their fitness to practice complaints and looking and making sure that differences that have occurred in ethnic groups are narrowed so that this process is more fair in terms of reporting and also then in terms of investigating. They've also been very clear that they want to eliminate discrimination, disadvantage, and unfairness in undergraduate and in postgraduate medical education by 2031. Now, as I've showed you, that's a huge undertaking. It's really important to do everything that is possible to narrow that gap. And it does involve that multifaceted understanding of how it's training and environment that probably makes the most difference and leads to differences in exam and in progression rather than the other way around. But as I said at the beginning, of course, ethnicity, an important protected characteristic, but one of many. And here is some data from the State of Medical Practice in 2021, which draws out some differences that are now being seen in terms of disabled and non-disabled doctors. And it's actually really scary. So we can see here that disabled doctors are overall more dissatisfied, and actually that dissatisfaction is growing. We can see that they are more likely to suffer burnout. We can see that they are more likely to have already taken hard steps towards leaving the profession. I guess it's not surprising given the complexities of COVID, given the increased demands on everyone for resilience and understanding how somebody who's coming to their job disabled again is having to be more resilient to get there and to struggle harder to succeed. It's unfair. The question really is upon us in terms of what we do about it. This is the Welcome and Valued report that was recently published on the GMC, and it gives us a good pointer. I don't have solutions. I think there are numerous opportunities that are around at the moment to make a difference. No one of them is going to crack any nut, but actually if we are open and we think about this in the round throughout, then we should be able to make a difference. Pathology is well placed. We have inquisitive, science-based clinicians. This is who we are. We are well placed to be able to question this data, to be able to understand what we can do better in the place, in exams and in our future professional lives to make a difference. And it's important that we do so. Thank you.